I'm delighted to welcome you to this, what is the second conference that we've run since HOBIC has been located at ISIS, and where we really have, for the first time, had the opportunity to work with data. And we see a growing number of scientists within ISIS and across the province using HOBIC data. And we hope by the end of the day that you will have some new ideas about how to use it, some research you might want to do, but also how to use it in terms of really looking at the quality of care that's going on in your facilities. Before we go on, I want to introduce Alison Blair. There's Alison. Alison is the person that HOBIC reports to within the ministry. But Alison has been associated with HOBIC back in the days when it was a nursing and health outcomes project. I'm going to read you Alison's titles because I can't remember what they are without reading them. She is currently the interim director of the health analytics branch of the ministry. But when she's finished this stint, she's going to go back to her old job, which is Director of Information Management Strategy and Policy. Wonderful titles. But in any case, Alison wants to bring some greetings, and I welcome her to the podium.
Thanks so much, Dot, and good morning, everybody. First, big welcome and thank you for having me here to give opening remarks at this symposium. As Dot was saying, it's the second annual, and so we'll look forward to hearing even more about the successes of HOBIC over the last little while. It's always exciting to see clinical practitioners as well as the research community and service providers coming together in one place, all with the joint goal of improving care for Ontarians. And Dot was right. I encountered HOBIC first when I was part of the health results team for information management, and we were looking at the Nursing Health Outcomes Project, or NHOP as we called it back then. And there was certainly the recognition that from a patient outcome perspective, this was the kind of information that was needed. And by that time, there had been a lot of research done on what the right measures were, and it was a matter of implementing. And so that is now a few years ago that I was there. As you know, HOBIC now has the ability to produce and collect standardized information across a number of sectors, so acute care, complex continuing care, long-term care, and home care, and it's sure come a long way over the years since it was the NHOP. And it's fantastic that HOBIC makes that information available also for a number of purposes, to improve patient care at the bedside, as well as health care planning, resource allocation, performance measurement, and research. And today there's even, and I'm sure Walter will get into this, but in other speaking engagements where Walter and I are on the same podium, most recently we've been talking about analysis of people who use the health system a fair bit. We nickname them the high-cost users. That doesn't sound like a really nice title, but it's folks who have lots of interactions with the healthcare system and wind up using a lot of its resources, probably because we aren't giving them the best care, the best coordinated care. And so there's even more emphasis right now on coordinated care plans to improve their outcomes and their experiences with the healthcare system. And so care planning and monitoring patients and understanding their outcomes is so important. And the health links, which were announced by the minister in December, are going to be groups of providers that are looking at these patients and trying to figure out how better to care for them so that their outcomes, both from a clinical perspective and also from a patient experience, are improved. And so those health links, one of the first things that they're talking to us about at the ministry is, how are we going to measure progress? And so this is something where HOBIC data will certainly be useful. And I'm sure that there are lots of researchers and health system planners who are looking at the HOBIC data and drooling at this point over this. Something that I wanted to relay, because it's been so powerful over the last little while, our minister, Deb Matthews, the Minister of Health and Long-Term Care, asks two questions every time she's talking about any project. One is, how will this help the patient? And the other is, how will this add value to the Ontario health system and really provide value to taxpayers? And so I think your themes and your topics today are absolutely bang on in terms of showing the value of HOBIC information and showing how it helps patients in the end, whether that's through bedside care or whether it's through research or through health system planning purposes. So today, I look forward to hearing about how the organizations and different researchers are using HOBIC to inform care and in the delivery of high quality, safe, and effective care. And I'd like to recognize the efforts of all of you who are working with HOBIC, either through the project or using the information to improve care. I'd also like to thank our partners in the HOBIC initiative, specifically ICES and the HOBIC team, for organizing the symposium today and providing a forum to discuss the opportunities to further enhance patient and nursing outcomes through this standardized and comprehensive information. It's my hope that you all enjoyed the day, and I really do appreciate folks having us leave early. I'm not sure what the snow is going to do, but hope that you take away some knowledge and inspiration to help us continue to improve care for Ontarians. Thanks very much.
Thank you, Allison. I'm going to do a little memory journey. I retired from HOBIC at the end of March. I thought, since we started in 1999, it probably wasn't too soon to be retiring. But when I think back to getting started in 1999, and Peggy and I were it when it came to HOBIC at that point, plus our expert panel, which was probably maybe the best group that I've ever had the opportunity to work with. At that time, there was agreement that we were kind of on the leading edge of trying to work with nursing-sensitive patient outcomes, whatever they were, and we didn't know what they were at that time, and moving them into online collection in the course of a nurse's working day and night, and collecting them onto databases that would then, and in real time, so the information would be available to nurses in real time, and then would be collected on a research database that would be available to the organizations and to researchers. Nobody else was doing it, so there wasn't a model that we could follow. And in 1999, when we put this expert panel together and began to get into the literature, and I think when we subsequently had the first conference, small invitational conference in 2001, and we invited Dr. Pamela Mitchell, who is at the University of Washington in Seattle. And Pam had done as much as anybody in working with nursing-sensitive outcomes conceptually. It was much more a conceptual exercise rather than a real exercise and something that had been mobilized. But at a talk that Pam gave at that meeting, she went back and did a Medline search on just the word outcomes for the years 1978 to 1989, and found that there were no references. And then when she looked at did the Medline between 1987 or 1997 and 2000, so just that 3-year period, there were 700. So it was in that decade of the 90s that really we began to see work being done on outcomes in general, and then some work on nursing-sensitive outcomes. I think if we looked at work in the decade between 2000, 2010, 2011, we'd probably find 7,000 at least references, because everything is about outcomes now. But again, back in 1999, we really struggled with what would constitute the battery of generic, that is not not related to a specialty in nursing, but a generic set of nursing-sensitive outcomes. And we needed evidence of their sensitivity, whatever we selected, their sensitivity to nursing care. So there wasn't a whole lot of research to draw on at that time. But I think looking back now, and we relied on a critical appraisal that Diane Doran and a team that she put together back in 2000, 2001, for the evidence for the outcomes that we selected. But I think in that decade since that we have felt confidence that we got the ones that we selected right. They have held up in terms of subsequent research. I think we're still short on the psychosocial, and I'm sure you run into that because there wasn't evidence. I think we all have beliefs about what nurses' contribution to patient care is on the psychosocial side. There just is not the research evidence to support that. I think that's beginning to accumulate now, and at some point will need to be added into the HOBIC battery. But I think it's still probably not strong enough to make that move. So the selecting the outcomes was only one aspect. The other was, how are we going to do this technologically? As the lead in HOBIC, I was no use whatsoever because I can hardly use a cell phone. Fortunately, we had Lynn Nagel, who was part of the team. And as we struggled with, okay, we need something that nurses where a patient can assess their patient and enter this online in real time. And so we need a device that they can enter this into. Well, first of all, there were not very many facilities back in, well, at this point, we're now moving forward. We've got the battery accepted by the ministry, great. We're told to implement, terrific. We're told to implement in 4 sectors, long-term care, home care, acute care, and complex continuing care. Yikes. And that we should begin this in 2006. That's when our budget came in. Okay. Just thinking back that 6-7 years ago, the difference in what's available technologically now from what was available then is immense. Struggled with, laptops were for the most part the choice. There were no tablets. Lynn told us they were coming, but they weren't here yet. And when she told us they were coming, we thought, that's good, what are they? But in terms of usefulness, we were really limited to laptops. And then how do you get them to the bedside? And they were expensive, let me tell you. At that point, we were looking at $2,000, $2,500 for a laptop. So when you're looking at the implementation, that gets very expensive, looking across the system. And then the issue around finding organizations that had the capacity for online implementation. They weren't very many. And we worked with the early adopters in 2006, and they were really pioneers at that time in working with us in terms of getting the interfaces worked out, and then educating the nurses on how to use them. It doesn't seem that long ago. And I think we've made great strides in this area, but there were a lot of nurses then who did not use computers. And so the whole business of learning how to input directly into a computer was a big learning curve for them, and to use scales for assessing patients, and therefore clicking on a number as opposed to writing out. We were still very much in the narrative and writing out what the patient's status was on admission, which was rarely looked at. once the nurses did those admissions, and certainly didn't end up on any database that could be utilized once the patient left the facility and therefore could be used for research purposes. That has moved forward enormously even in this time period where there's a lot more facility of nurses in the practice environments. So we've come a long way, and it's even though it's not been a long time in years. But in this time, there's been a huge advance in terms of infrastructure and practice. And I say it's not a minute too soon. As part of my retirement, I've decided you've got to figure out what your retirement's going to be. And I didn't realize I was devoting my retirement to Health Quality Ontario, but it's turned out that's been a big part of it, but with enormous satisfaction. But you will know about, because they began to be implemented in 2012, the QEPs, quality-based, could I say QBPs, quality-based procedures. 4 of them were introduced in 2012. I think there are another 14 coming this year, up to 30 by 2015. And these are where essentially we have an evidence-based map of care from the time a patient comes into an emergency room and then is discharged. The Health Quality Ontario was asked to develop these care paths for 3 of the QBPs, congestive heart failure, COPD, and stroke. And I got to be chair of the steering committee for these 3. And I went to all of the meetings of the expert panels just to get a feel for what was going on. I was very impressed with the work that was done. Most of it, though, these paths are about medicine. They're about physician decisions. Very little about nursing or physio or respiratory therapy or occupational therapy. Partly it was we don't have the evidence in hand to contribute to this is what nursing should be doing here. Physicians are ahead of us, quite a ways ahead of us in using that. But since these are being moved into the system, and what is going to be needed is evidence of how well patients are doing as they are admitted and then on discharge. And for physicians, there is some evidence. There certainly is evidence of what is done because that gets transferred from either the costing side of things or the outcomes. But frankly, when you think of, for example, COPD and the HOBIC outcomes, hospitals that have HOBIC will have information available to them that they can use that hospitals that aren't still on board simply won't have. Because again, back to COPD, dyspnea, fatigue, functional status, therapeutic self-care. Same when you think of congestive heart failure. You can really look at those HOBIC outcomes, and that's why I think for the ones we selected, we got them right because they are universally useful in looking at what's the patient's status on discharge. And so I think these hospitals are going to be, hospitals with HOBIC are going to be ahead of the game in having the information that they require to demonstrate how well they are in fact following their these critical pathways. Other thing that HOBIC has now led us to, and it's really what we're going to hear about today, is the value of HOBIC for research. And it's where we have databases, and this has been the great advance for us since moving to ISIS, of having the research database up and running and available to researchers. And as ISIS has moved across the province in terms of establishing centers in the academic health science centers, it's made it that much easier for researchers in those academic health science centers to access the data. So we're now in a position to use HOBIC data to advance our understanding of what is effective in nursing interventions, and enhancing patient outcomes. So today's conference is focused on what can be learned about patient outcomes relative to common patient health situations, what we can learn from HOBIC data, and what hospitals can learn from HOBIC data about the quality of care that they deliver. I think this conference could not have been held 5 years ago. HOBIC was ahead of its time, but now the time is really for HOBIC, and I think the time has caught up to HOBIC. So I think it's time to get started and hear what HOBIC has to offer you and how you're taking advantage of this.